but in systems, so that even if people will change in the future, but there will be systems in place that allow us to work in more business mindsets, but also without forgetting the mission of the church, and that's to provide services to the vulnerable and the poor. Thank you.
Thank you, Dr. Kwai. When you mentioned that the FBO Health facilities are the leading provider of referral services in the rural setting, that takes me direct to Dr. Ringo. I know dialysis, is it specialized or super specialized services? I think AHN is among the largest dialysis service providers in the country. And you also work with FBOs. So what roles do you play in advancing health? And in your answer, please give us practical experience of working with faith-based hospitals in Tanzania. Karibu.
Yeah, thank you. As the moderator have already introduced me, come from Africa Healthcare Network. And for the benefit of those who don't know about Africa Healthcare Network, Africa Healthcare Network is a private company which has invested in Africa, especially in Tanzania, Rwanda, Kenya, and now Zambia. And in Tanzania, we started in 2017, but the company was incorporated in 2015, starting from Rwanda. And to date, the mission of the company is to provide the quality, to make sure that there's an availability of the quality, accessible quality healthcare in terms of dialysis services across the Africa. And we have a total of around 18 centers in Tanzania which are providing dialysis, which makes us as a market leader in terms of share of 23, about 24% of the market, but actually we are saving around 20% of all the patients who are living with chronic kidney disease. So far we are attending like more than 500 patients and doing almost 60,000 plus sessions every year. And actually, to answer your question, is that African Healthcare Network has leveraged and tried to tap the resources still available, the network of the FBO facilities, the infrastructure, whereby coming in and set up a state-of-the-art dialysis center, putting all the investment from the infrastructure, which means the building, funding with all the equipment, starting from the machines, reverse osmosis plants, but also we go ahead and do the build with the staff, and also dealing with the provision of the high quality consumables or dialysis kits, so that we can provide that service. So our major role here now comes in terms of ensuring there's accessibility, availability and accessibility of this dialysis service, which is very rare. And we have managed to partner with these FBO facilities, which have got the deep roots in the community, especially in the remote areas. So making us also reaching those people who are living there. And also in terms of, apart from availability of product, actually we show that we provide quality services at a high standard to the population. And through this we are doing through make sure that we have professionals, university professionals like nephrologists, nurses who will be able to provide the service, but also invest, as I said before, investing in the high quality machines. But another thing also we do in terms of capacity building and also training. Before, when we are starting these services, we do intensive training to the healthcare providers, professionals like nurses, also said nephrologists, physicians, medical doctors, to ensure that they'll be able to provide their services. So they undergo around 6 months intensive training, 3 months internal training, and also 3 months will be attached to higher centers like KSSC as well for further training and also accreditation. But also we provide collaboration. We collaborate with the public and also collaborate with the private sectors, especially FPO, but also for public in terms of ensuring that we provide services, we contributing to the police, also advocacy, working with the Ministry of Peerage, but also working with other stakeholders, bilateral donors or other development partners as well. But another thing also, our role is to make sure that at least we can contribute into the addressing the, or we put the contribution on the national healthcare goals, especially on the non-communicable diseases. As you know, that renal problems or renal kidney problems is one of the non-communicable diseases. So we collaborate with the other stakeholders, especially the government, also to provide preventive measures, apart from curative care, but also preventive care, conducting training, also health education, but also conducting camp screenings and things of the sort. When it comes to practical experience, is that we've been able to work with FPO facilities, and these facilities are being located. Most of them are, as Chakwaya said, they are in the remote area, hard to reach areas. So we also saw that taking these services to these remote areas also will benefit from those people who at one time they have to live, once they're diagnosed with chronic kidney disease, most of them they relocate to urban. They live behind the economic activities. They start relocating, starting a new life in the towns. So they have a lot of costs. So having a center in an area like Peramiho, which we have a center, in Kinga we have a center, also Haydon, has helped this patient to relocate from where they are going, maybe from Dar es Salaam, from Arusha town, back to their village or back to their local areas to continue with the services. So another thing also, as Dr. Kwaya said, that they are trying to also support these RFPA facilities to be non-independent to the donors of the government through adoption of the market-based approach. So this private partnership we are doing these facilities also comes with a benefit. Like there are some additional services this hospital is going to receive, like the revenue share from the services we're providing the dialysis sessions, but also they are going to, they normally receive more revenue from other ancillary services like laboratory, other areas like farmers, farm procedures and things like that. So that is a nutshell, like I said, of the experience we've seen. So we have supported hospitals as well to be self-reliant, to be independent. Thank you.
Thank you very much, Dr. Rengo. And now we are going to move a little bit from doctors. We're going to someone who holds our money, the bank. Mr. James, I know there has been hesitance, most financial institutions, to lend to the health facilities. But we were looking at facilities, most facilities that have taken loans from banks. Majority of our facilities have taken it from Mkombozi Bank. What do you see in our facilities that other banks do not see?
Thank you, Mr. Moderator. As you introduced me, my name is James Mayama. I'm from Mkombozi Commercial Bank. In a nutshell, Mkombozi Commercial Bank is majority owned by the Catholic Church, but it has been listed in the stock market. So it's a commercial bank that is full-fledged, operating in Tanzania with a maximum of 13 branches, with more than 3,000 agents and mini branches. So we are operating across the country, and FOBs or health sector is one among the sectors that we are supporting heavily, because we saw an opportunity while others were hesitating to support what actually FOBs were So Kombozi Commercial Bank, why we decided to support FOBs is because first what we did, it was much necessary for us to analyze what are the challenges that are facing these FOBs. Then having analyzed the challenges, then we came out with a solution. One of the biggest challenges that we saw was the funding management. That these FOBs were operating, but when it comes to revenue collection, it was not that much sufficient. Most of the revenues they had a lot of leakages in terms of revenues. So one thing we did was to streamline the financial management to those particular health facilities, so that they can be able, if they are to take a loan facility, then they will be able to repay. So after making that rearrange with those health facilities, and they were able to streamline themselves, then we decided to support them financially. So we came to note that these health facilities, they have very good cash flow, but it was just how to manage those funds, those collections that they were receiving. So we started now to give them a sort of financial advice, a sort of technical advice on how to manage funds. And after doing that, also after taking a loan facility, what to do with those loan facilities, avoiding unnecessary diversion of funds. So having doing that, we came to realize that they were capable. And actually, out of I can fairly comment that 100% of all the health facilities that we gave them loan facilities, they are performing very well. Some of them, they took money for project financing. Some of them took money for working capital purposes. Also, some of them for other related purposes. But all of them are performing very well. But the streamlining of cash flow, and also making sure we digitize the collection, the revenue collection, was of paramount, because we made them capable of repaying the loan facilities. And also, we came to notice that some of our financial services, financial institutions in the market, why are they hesitating to support FOBs? It's because maybe nature of the ownership. These FOBs mostly are being owned by, they're church-based, or they're owned by religious institutions. So when it comes to the ownership, and how when you analyze those facilities, then it's something technical which one has to be very much familiar with what should be done. So on our side in Kombozi, we had also to study the ownership, the structure of ownership, but also how things, who are the decision makers, and also how the entire management structure of those health facilities. So knowing those all those parameters, then it was easy for us to chip in and also give them funds. And as I said, they are doing very well. So responding to your question, Mr. Moderator, it was just because we saw an opportunity which actually others did not see, because of first, we had to know what are the issues that our colleagues are hesitating. So knowing the issues, both on cash flow and also on the management, we decided to engage our teams, and also advising these health facilities on what to do. And they agreed with us, and thereafter we decided to fund them, and now they are doing very well in those loan facilities that we extended to them. So it was a matter of analyzing and knowing what are the challenges and how we can address those challenges that make the Kombozi Commercial Bank to be the major financier to these FOBs. Thank you.
Thank you very much. Thank you. You have shown us that even the faith-based facilities now can lend and get money from the banks. Mr. Godfrey Nyombi, I know you said has been a key development partner in health in supporting private sector. Now, can you tell us what's the role of development partners like you in supporting private sector in the health? And what has been the USAID contribution to this effort?
Great, thank you. Thank you so much, Isaiah. And I want to express our gratitude for being here on behalf of USAID. First of all, we define private sector broader than just a core definition of private sector. We understand private sector goes beyond the common non-private for-profit, but also we go through, look around private sector as foundations, classifying them into private sector, and non-profit faith-based organization, classifying them as private sector as well. And anyone else who is working around areas around practice related to market-based segmentation, market-based approaches, all of those are, to us, are defined as private partners that we work with. And at some point, we also have seen private practice within the government, which is the public. So we also understand private practice goes even beyond to that level. So our understanding, and I think this may be coming later, is working just beyond looking at private sector as a profit-oriented scope. So USAID as one of the donor and key playing into the private sector in the health sector, we have first of all been acting as a convener between a problem and a solution. So most cases in health, in development, we have challenges, and we are best to identify the challenges by putting ourselves in the middle to also find who can bring the solution. And some of these solutions are really very massive and very much available in the private sector. Sometimes it's not easy to connect the two. The private sector may not find it easy to engage in health, and health may also not find very easy to engage in health with private sector. So we sit in the middle there as a convener to try to bring the development problem with the private sector and find a solution altogether there. I think we have examples, as Godfrey just mentioned, our work with partner. We brought in work with telecom companies. Out of nowhere, it may be very difficult to think about how can a telecom company work in health. But we have examples like in Mama right now, which is USAID supported. We've worked with banks. I know James has spoken very well about how it has been very hesitant to work with health, particularly in faith-based organizational facilities. But we've worked with banks to make to address their concerns, and major of their concerns is the risks that are associated with giving money to a place where people always come to consume services. So creating the viability of faith-based organization or private sector to be able to get money from the banks. But we work with small facilities like very lower level, like the adults, the private pharmacies, all of this just to make sure that in the comprehensive nature of development in health, we need everyone to work. We need everyone to have the ability to play and contribute into it. So what has been our role in another way also has been to create and support the governance structures of the private sector, including the definition that I have, so that they may be able to be seen as stakeholders and partners working with the government and working with other persons on the ground. What we've been supporting also has been to enable them to get the working capital to run some of these facilities, but also borrowing a lot of business practices from the private sector to the health sector. We've borrowed lessons from companies like Coca-Cola. We've borrowed lessons from companies like breweries. In their processes, there are things that are very critical and important for our health sector to learn. And also, I've mentioned about market-based approach and segmentation. We believe that there's so much that our healthcare has been missing by not segmenting our market based on the demand. We're living in a world where the demand for health services varies a lot. So creating those practices has really been our key role to play, and we've seen good results so far, and really not discouraged about what is happening at this moment. Maybe I'll pause there. Thank you.
Thank you. Let me just connect next from there, you say the way you define the private sector, the way people are thinking about yes, profit making. I know it is risk supporting private sector. You as USA, it is more appealing to support public institutions, politically, rather than non-profit, yes, as we are. So, how do you ensure that the resources that you provide yield the intended results?
Thanks. As you've said, I think we know for sure that healthcare has been much a public sector service in most countries, and not only Tanzania. But the push to move to the private sector has been key to just one factor, one big factor. All of us, including us here, always expect that when we go to the healthcare environment, we get a quality service. Quality is the key factor. So it's not about the money we put, it's not about the time we put into this, it's more about are we getting the quality out of the healthcare that we invest in. And to get the quality out of it needs to be more. You need efficiencies and you need effectiveness. So any compelling proposal, any compelling reason for us to work into ensuring that we have more efficiencies that are looking to the sustainability of it as well. And having partnership with the private sector that is not, it's a partnership, there's a difference when we see it as Mkombozi being a partner rather than being only a recipient of support. And I think that's where CSSC really look into heading into that. So that gives us that hope and positive courage that what we're putting in really leads into a partnership, not only being a recipient. So I think the challenge to most cases in how we avoid or try to avoid the risk associated into that is looking into the perspective of like, are we in partnership or are we going to be a recipient? Are we creating another recipient or another pocket instead of creating or leveraging into creating a business that can self-run and be able to, remember it's about creating a business. So we have to move from like creating more recipient, but more creating businesses that can run. All of this facility right now, working with the banks, I believe banks have the tendency of working with business people. So we're creating businesses. These facilities are now running as business, from their boards to their operations, to their financial management systems. That allows any donor to be very comfortable and avoid and be comfortable of the risk that may be associated.
Thank you very much. Now, back to the money guy. Please, briefly, when we have a short time, there are so many bureaucratic, regulatory, legal, policy frameworks that hinders the health sector from accessing loans, financial resources from banks. So, what do you do about that? How do you help the facilities? And how you as a bank try to help the health sectors?
Thank you. Yeah, it's very true. The environment that we are working in has some legal challenges, policies which they're not a little bit friendly to the sector. But as a commercial bank, we do have some forums, and which through those forums we are using them to make noises, to try actually convincing the decision makers that we are working with this sector, but we have seen this number of challenges. Please, 1, 2, 3 have to be done actually to soften and also make the environment that much friendly. So we are using the likes of TBA, Tanzania Bankers Association. It's one of the forums that we're using it to take our concerns when it comes to health sector financing, because a lot actually is it has been a lot of challenges are there. So using through the TBA, which is Bankers Association, we are taking those challenges to the ministries, whether it's Ministry of Finance or the Health Ministry, but also through via the Central Bank. We are trying to channel all these issues to various partners so that we can see some improvements. Of course, we have seen some improvements. Some of the policies are being being softened compared to where we were before. But still, we are still pushing to make sure that the environment is much more friendly compared to where we are much more friendly. So, as a commercial bank, we know this is a very big challenge. But what we are doing as using the forum that we have is to keep on using the union that we have, the association that all commercial banks are falling under, to keep on meeting the decision makers and advise them on what we can do to make this sector more friendly and also for them to be able to access funds from commercial banks.
Thank you very much. We are going to come to you after these two questions. So get prepared. If you have a question, I would like to have the microphone in the audience. So get prepared with your question, then I'll ask two questions. Dr. Kwai, what has been the key takeaway from the pilot project, and how are you planning to scale this to the entire network?
Thank you. I think Godfrey has said it all, so I'll be brief. That quality is expensive, and definitely someone has to pay for that quality. And there are people who are ready to pay for it. People go for quality and they pay for it. We should just, in partnership with the government and other stakeholders, create good environment to allow health sector also to segment, like to provide different segment of services that allows people who can pay to pay for services. And one of the persons who do not believe that everyone who have chronic illnesses like HIV, TB, diabetes, that they are poor, they can still contribute for services. And definitely private sector is also reducing the burden on the government for those who would go for free services to at least pay for services and get quality care. We have started with few facilities, around 22 hospitals, but now we have seen that it really works. Revenue has increased by more than 70% in 3-4 years. Even the number of clients has improved more than 28%, so it's possible. So we are now trying to develop an efficient way of reaching our network of 950 health facilities by leveraging on technology, like having like central training with the remote, reaching all the 900 health facilities, creating systems that will improve efficiency within the health facilities. As you know, if you want to provide quality services, then efficiency is the key, but also improving internal controls and also using the existing forums where the facilities meet to kind of now build their capacity to be able to strengthen their internal controls, quality of care within their health facilities, so that all the 900 health facilities can be on board. Because we have now seen with the 22 hospitals that it is possible to be self-dependent, but also still keep the mission of the church providing services to the poor and the marginalized.
Certainly, and also the very well short summary. What is the current position of the church in advancing PPPs in health? What are you doing on the ground?
Yeah, thank you very much. Actually, I can say that the FBO facilities are strategic partners, of which we know that their aim is to provide the quality healthcare solution to the marginalized, to underserved, and also to have reach to those areas which are not reachable. So, as HN, we continue to invest in healthcare, especially the FBO. And also currently we are doing that. We are still doing that. We have some few projects which are coming up, around 6 projects for new services. Actually, we are doing this because we are trying to leverage in terms of ensuring that this FBO, instead of putting resources into establishing these services, they can use that resource to other areas. Let us AHN come in and put in this, structure. But also, we believe that we continue to share experience, training to the management, but also we continue to support them in terms of for them reaching out to higher levels. We have seen some example of some of the hospitals they have grown from district level hospital to the regional level hospital just because they managed to embrace specialized services. But also bridging some of the other gaps as have been mentioned by Manyama in terms of the daily capacity of these hospitals and financial management. This has been a challenge we have seen, of which we are trying also to manage them through various discussions with these facilities. But also, as I said, HN is a private company. Yes, it is a private for profit. But actually what we do is that we are not only looking for getting profit, but we continue to support these facilities in terms of some support of charities. There are some patients who are not being able to pay, for the services, for the sessions or for the other services. HN also have been forwarded to support these patients, making sure that they access the services. So our role here is to complement and support these FPA facilities to reach their goal of providing social services or health services to the population.
Asante sana. Now to you, back to you. Do you have any questions for the panelists here? I have one hand there, please. Another hand there, 3. So you take only these 3 and then we'll see if time allows. Good morning.
Thank you very much for the wonderful presentation regarding this forum. And I have some few questions for all the presenters. My name is Mr. Gen Zakaria. I'm the head director from Deloitte. At Deloitte, we are implementing 2 USAID funded projects. One is called the Sodari Southern Project, and the other is Afiyamo Southern Project. So I'm very much interested in the topic, especially on the engagement of the private sector to leverage on the sector performance. So starting with the presentation from Dr. Prime, I just need to know more on the point of sustainability. It just touched base, but it didn't come out very clear how sustainable it is when it comes to the issue of SSF's provisions with the engagement of the private sector. And the other question, the second question goes to Dr. Ringo. I would love to know, I was very happy to hear that Dr. Ringo is coming from African Healthcare Network, but I would love to know if the focus is only on dialysis or there is a plan to expand the scope, because health sector is starting across different areas, and by the name of the organization it says Africa, so Healthcare Network, so we are expecting like it should leverage different areas so that organizations who are working in different segments can also think the best way we can network or partner with this network.
Thank you.
The other question goes to my friend, my brother Manyama, and this is on the aspect of I was wondering, I appreciate the participation of the collaboration that they're doing, but I was wondering if there's some segment of corporate social responsibility that the bank is giving to this, or it's just a partnership on the side of supporting the financial aid network. Thank you.
Asante. There was another hand, please. Go straight to the question. Straight to the question.
Thank you. Mine has already been asked. It was about CSR.
Thank you. Yes, another hand, yeah.
Thank you very much. My name is Dr. Maneno Suka. I appreciate for the presentation. So I have competition they are going through and be able to sustain, as you have said here. Right now, the donations from different donors are down, and again, there are challenges with the facilities, especially at the area of governance, because it is really one of the challenges. I work with these FDOs, and when we meet in different conferences, among the issues addressed are the challenges in governance. Now, with all other innovations, I don't know if they can wait without starting with the first issue of governance structures, which is a very big problem. What is the concrete measure?
Thank you very much for questions. Dr. Kwai, you start, and then Reed.
Okay, thank you. Someone asked about sustainability. So as I say, we're investing in systems rather than people, right? So first, we're making sure that the system really allows for these innovations to be implemented in a smooth way at our facilities. For example, the hospitals that we are supporting, they've all developed strategic plans, and that includes sustainability measures. So we ensure that in the next 5 years, when they're implementing their strategic plan, they will at the same time be implementing their sustainability strategies. But as I said, when we started, something that we really needed to do is to change the mindset of the owners and of the managers and also of the society around these facilities. So now the owners know that in order for us to sustain, we need additional revenue. And this revenue should come from the services that we're providing because it's the core business. So even the people they put in the leadership position, they make sure that they have the capacity and they have a better understanding of the business environment around the health sector. But I think now to connect with the question of governance and leadership, that's where we are really investing our efforts to make sure that we really build their capacity, because unfortunately for the healthcare workers, when they train in the medical schools, they are not taught about business or financial sustainability or things of the sort. So we have first started to invest in that, changing the formation of our facility governing committee or hospital boards to make sure that it really contains people who have experience and they have the capacity to manage health facilities, but they are well knowledgeable about business in health sector. We have developed guidelines now that will be guiding the formation of hospital boards even in the longer term. So that's one, but also at CSSC we are creating a center that will be continuously providing trainings, especially business trainings, to the healthcare managers so that they'll have the understanding of the business sector, business in health sector, and different innovations of generating additional revenue. And we're all pushed to invest in this because we have seen it really works, because the 22 hospitals that we're supporting, for example, in 3 years we looked at their income from the health insurance. It has gone up by more than 84%. But looking at the hospitals that we have not supported, their growth has been less than 30%. So definitely all the hospitals across our network needs this type of trainings so that they can generate additional revenue, and this is by doing market segmentation, using different market-based approaches to generate additional revenue. But as we have seen, we have untapped opportunities working with the financial institutions like the banks to providing working capital and loan of different types, but working with different companies like diagnostic companies, AHN, to kind of support us in doing more investment. As I said, quality it's expensive and it needs more investment. So the existence of the private sector would really help us in the longer term to sustain these hospitals.
Yeah, thank you. To answer the question from Zakaria from Deloitte, actually, when we say that there's actually we don't only deal with dialysis and dialysis. There are other programs also we're dealing with when we're providing this care. One of them being mental health support to these patients, but also do the support in terms of nutritional support. But actually, as a company, we are looking forward to seeing if we go and support these patients also to go to renal transplant. Start also collaborating with other partners to ensure that maybe we can start this program for renal transplant. But also, there are other areas that's never been tapped in terms of country, context, such as home dialysis. For the time being, we are doing center dialysis, but actually there are a way we can go ahead and do some, we call it home dialysis. But also, the other convenient way as well, in terms of peritoneal dialysis. This is an area also we are trying to look and tap this and make sure that at least we can bring this to the country. But not only that we are doing dialysis, but also we are engaging in preventive programs to ensure that people do not go into that one. But another thing is also, maybe you wanted to see if we can vertically expand, maybe doing other specialties as well. Of recent, we have started doing thinking about oncology, so that we can integrate the oncology with the existing of our network of our facilities. So far we are continuing to come up with a sustainable healthcare model, which will enable private sector and also just like us to see how we can integrate other services as well. And also the private sectors can be a player in this kind of models.
Santi, question about CSR.
Yes. Thank you. To respond to a question of my dear brother Zakaria, and also another question, the same question came from Madam, who were also asking for is composite commercial bank also doing CSR. Yes, we do, and we normally have this CSR in our budget, annual budget, and for this year we had it, and we did at we had to provide some support at Lexo and Mwanza, one of the referral hospital, but also in northern zone, that is Moshi. So we are going also to have it in next year budget as well. So we do have CSR without even segmenting which type of health facility, whichever the health facility that we once analyzed and we see it is necessary to be supported, to be considered in this segment. As a bank, we normally have this CSR for those health facilities.
There was no question for USA, but what do you see in the future? What's about sustainability? What are your plans?
First of all, I think I wanted just to say all of us here could be good ambassadors to what private sector is, and I think we'll see that we're heading, the healthcare system both in Zanzibar and mainland is heading to a very big picture, like as we're talking about universal health insurance. Key to universal health insurance is quality. Quality will be the key driver. So our future of health financing will really depend on how much we invest into creating quality and quality health services. We should also look into the private sector business models. Some of these things tend a little bit different, negative to most people in the healthcare. It looks like it's bad to do business in the health sector. It looks like it's bad to do profit in the health sector. But I'm not propagating for like get more richer for serving people. But I'm into like we look into healthcare needs investment. As Dr. just keep on saying, quality needs money. So we can't run facilities in the way that we are always running into losses. We have to make sure that we're not getting losses. That's what the banks are doing. That's what everyone in business is doing. And that is sustainability. If we are able to run these facilities, about 800 facilities, in the way that they can generate their own money and they can run their own care with quality And if we replicate that to the entire, even the government is doing the same. Facilities have to run in a business model, they have to do their revenue, they have to manage their revenue. That's sustainability for me. I think it's
It was very interesting hearing that facilities lending from your bank. I would like to know which type of loan were they? Were they small, medium, or big loans? As you said, that repayment rate is almost 100%. So, and if you can define the small ranges, how much? Likewise, the remaining. The second question is about collaterals. Did you consider this while lending these facilities? Because as much as I know, collaterals, especially to faith-based facilities, is a bit of challenge. So if you can say something in terms of collaterals, I would love very much. Thank you.
Asante, kimbiza swali la haraka haraka tumalizie.
So we have 3 minutes. I think this will be the last question.
Okay, so my question to the dialysis organization, like it looks like a very good business model, and would you share, because I don't see other models, other organizations copying your model, maybe not on dialysis, but maybe lab, diagnostics. So it saves the hospitals need to invest on infrastructure, but someone can come and share the profit. Is this something hospitals are thinking about to spread not only on dialysis, but on other services? Maybe to complement my colleagues, question from Kombozi, like how do you handle collaterals, but also how do you prepare to handle the emotions related to when there is a default and you have to recover your loan?
Asante. Karibu Manyama, and then Dr. Ringo will finish everything.
Thank you. Maybe I should start with the last question. How do we take when someone defaults? Yes, if it happens, it's normal in our business lending practice that you give out a loan and somehow, somewhere, you are a very good client, fails to meet all the events, that is to repay the loan facilities accordingly. But as a bank, we do have, first, we do have room for discussion and see what went wrong. And this is very key. And knowing what went wrong, and also we have to sit down and reanalyze the cash flow of our customer, that maybe there is a turbulence on the cash flow, that either the cash flow has depleted, so at that moment one cannot be able to meet or to repay the loan. So the option that we normally take is to restructure that facility. We restructure that facility to a period that is that will give you a relief, that is a repayment, an installment which is affordable at that particular moment until the business now resumes to a normal condition. So we have a room instead of it's a last resort if we are to decide to go and maybe auction the collaterals. But since the business are there and it was just a challenge, maybe one or two, then we have to analyze those challenges, but also advise our customer going forward what should be done. But also we have, and the best option, we normally restructure those facilities and give a room our dear customer to start repaying in according to the current cash flow that the institution has. So this is what Mkombozi Bank is doing. So it doesn't mean that having a performance that some are not they are not defaulting. They are defaulting, but we normally have a chance also to discuss and advise the customer, but also giving them enough time to repay, because our loan facilities are being repaid for a maximum of 5 years, with a grace period of 12 months. So you find a repayment period of almost 7 years. And in that particular period, one can be able to repay without even paying an interest. That is a moratorium period of a year. If at all it's a construction financing, that we give you a financing that you don't pay an interest or neither principal for a period of 1 year. Then after that period, we believe the project will commence, and now you start repaying. So we are even during the restructuring, we normally consider those periods that we give our customer a reasonable amount, a reasonable period with amount that is affordable at that particular period. So this is what Mkombozi Bank is doing. Another question came to Madam that which type of loan facilities are we offering as Mkombozi? We have a number of facilities, but to mention few, for these health facilities.
Just to mention.
Yes, we have overdraft facilities. These are working capitals that if one has to pay you take a loan facility for operating purposes, then Mkombozi Commercial Bank is giving you that a loan facility or an overdraft facility. But also we have another facility, is a project financing, that is a construction facility. An OD is being repaid for a maximum of 1 year, but a construction facility, it goes to 7 years. It depends on the wishes of our customer, but also depending on the analysis that as a bank will have to analyze and recommend on basing on the cash flow. So we have that project financing, but also we have asset-based financing. That is we are giving you loans to acquire various assets, whether it's machines, the MRIs, CT scans, but also vehicles, these vans and etc., just for supporting the operation of the hospital. So we have those type of facilities, overdraft, but also asset-based financing is there. So it depends on wishes, who a customer wants what. So Mkombozi Commercial Bank is having those lines of credit facilities to health facilities. But also we have another one, which is we call it an invoice discounting. That if you have raised an invoice, maybe to be paid by a certain insurance company, and they have not paid you, Mkombozi Commercial Bank is giving you 90% of what you are claiming. During that particular period, you are waiting for the amount to be reimbursed by health insurance anyway. So we give you that facility. After being paid, then Mkombozi is taking just 1% per quarter, 1% per quarter of what has been reimbursed, disbursed to you. So we give you 90% of your invoice claim to the healthy insurance company, and then you start using it. Once you are being paid, then you liquidate the entire facility that you have been given. Lastly, is on.
That's
yes.
enough. For the rest, I think she will follow up.
All right, thank you.
Dr. Ringo, half a minute. We are going to be chased here.
Yeah, thank you. Actually, as HN, we have seen that there's a need for these services, and that's why we came up with that kind of a model. And I believe as HN, we are very good. We have good expertise in terms of dialysis services. That's why I said like we are developing these sustainable models so that at least other people also can check and can use the same as well. So I think maybe for the interest of time, if you have more questions, we can have some discussions out of this. Thank you very much.
Yes, the person is called Dr. Peter Risha. You can see him after here. Thank you very much for participating in our forum. I know we're running shortage of time. We have to end here. You can see any one of these people here after, as we go to the next forum or during this time of THS, and come again when CSSC welcomes you in our forum. It's been a pleasure having you. Have a good afternoon.
Thank you. Thank you very much, Dr. David, our moderator, and the panelists. We can give more clap of applause. As he has already said, we can get more time to interact and to network and for many more questions. So now we are marking the end of our session, and we are required to go to the main auditorium at the Stone Town Hall for the following preliminary session. So thank you very much for your participation, and let's go to the main auditorium.